Well, thank you, Dr. Butler, for the invitation, of course. And thanks, Manny, for that great talk. It's really exciting, I think, for our patients. So I'm going to talk about intravenous albumin. I think I had a pithy title that I sent to Alyssa, but I forgot to put here. So it's the do's, don'ts, and don't knows of intravenous albumin that we're going to be talking about today. I have nothing to disclose. I should disclose that I gave a talk on albumin 6 years ago at the gathering formerly known as Renal Grand Rounds. And just as a cautionary tale to any of you choosing topics out there, I thought I was just going to give a little talk on albumin and that was going to be it. And then it spawned a review article, and then somehow I wound up as the ASN representative on a guidelines committee for albumin. And so here we are 6 years later talking about albumin again, and I'm excited to share the results of that guideline effort. So the outline is here. I'm going to talk just a little bit about the history of albumin as a therapeutic agent, and really sort of the sort of ups and downs of albumin, as it were. And then I'll talk about the guidelines, so the use of intravenous albumin, a guideline for the International Collaboration for Transfusion Medicine. Being a hepatopnephrologist, we'll take a closer look at the role of albumin specifically in patients with liver disease, and then I'll just end with a brief note about how I tend to use albumin. And so we'll start in the past. The first time that albumin was really used as a therapeutic agent was back in the 40s. The US military had the human albumin program where it was actually used in the field for resuscitation. And, I think it was used in various contexts in the subsequent decades, but it wasn't until the 1970s that it began to show up in randomized trials. So in 1975, there was the first randomized control trial using albumin versus what we now would call crystalloid during surgery, showing unsurprisingly that the more albumin you gave, the higher the oncotic pressure in patients. And then in the 90s, really, there was this trend towards demonstrating that there was an association between serum albumin and mortality. So we're not talking about giving albumin necessarily, but just the observation that if your patients had lower albumin, that tended to be associated with mortality. And that was true in all patients, but also in dialysis patients. Right, and so this is relevant to the current group, albumin in hemodialysis patients. The odds ratio for mortality goes up considerably as the serum albumin level drops. And so there was lots of interest in using albumin potentially to remedy this problem. But you could say the pendulum swung in the direction of using albumin, but then there was a Cochrane review published in 1998 showing that there was potentially an excess mortality of 6% or one excess death per 17 patients treated with albumin in a systematic review of randomized control trials. And so the whole kind of community really pumped the brakes on the use of albumin. And in fact, the FDA issued a letter saying, until the results of further well-focused studies are available, the FDA urges treating physicians to exercise discretion in the use of albumin. And I think it's probably always good to exercise discretion in the use of things we're prescribing, but this kind of poured cold water on the use of albumin, and we'll continue that sort of story a little bit later. The FDA's response a few years later to a couple of large trials. But what you'll see then in the era from 1998, when that FDA letter was published, until in the next 20 years, was a flurry of studies trying to demonstrate a benefit from albumin in different contexts. So the clinicaltrials.gov shows over 1,200 studies where albumin was the intervention in that 2-decade period. And unsurprisingly, in this context of looking at albumin, we see albumin use increasing over these years. So this was one retrospective look, looking at patients in the hospital receiving albumin as a percent of all discharges. And you can see here that in all patients, hospitalized patients, the percent receiving albumin was increasing on a yearly basis about a decade ago. This is significant for a lot of reasons, not least because we don't actually have great data to guide us about whether albumin is beneficial, but also because albumin is quite expensive. And so the estimated cost of albumin in 2009 was $235 million. And in 2013, it was up to $468 million, which is almost $5 million per hospital, just the cost for using albumin in this era. And so the use was increasing. The use is costly. Here are a little bit of outdated, perhaps, numbers from our hospital system here at UW, but the cost to the hospital for 25% albumin is $63 compared with $1.50 for crystalloid. The cost to the patient is $360 versus $82 for crystalloid. So the cost is significant, and importantly, as we'll discuss for kind of the rest of the talk here, frequently the use of albumin is inappropriate. And so this was again a retrospective look at an intervention that some pharmacists did in the hospital system to try and decrease the inappropriate use of albumin. But prior to their intervention, they estimated that 63% of the albumin used in their hospital system was used inappropriately. And so, with that as kind of prologue, I think there's need for a guideline to help us think about the context in which we should and should not be using albumin. And I think that's really the purpose of a guideline, right? It's not just to tell us what to do, but also to tell us what not to do, or to raise questions for future study where we don't know whether albumin is beneficial or not. So I had the privilege of participating in this group. It was a great experience for me. And I am happy to tell you about our recommendations. We use the GRADE methodology, which I think many of you are familiar with. I'm certainly not an expert in this. I'm not going to belabor the point too much. But the idea is that you assess the certainty of evidence of your recommendation based on the type of studies that are informing that. And then based on various domains, you could either upgrade or downgrade the certainty of evidence such that what you're left with at the end is either high, moderate, low, or very low certainty of the evidence. And I will direct your attention to this portion here. The low or very low certainty of the evidence is where we're going to spend most of our conversation, because there's no high certainty of evidence recommendations and only one moderate. And that just sort of speaks to the quality of evidence that we're dealing with when we're looking at albumin. So the committee made recommendations for patients in the following clinical settings. So recommendations for critically ill adult patients, specifically critically ill pediatric patients with severe infections, neonates in critical care, patients undergoing kidney replacement therapy, patients undergoing cardiac or vascular surgery, and patients with cirrhosis. And in the interest of time, with apologies to our pediatric colleagues, I'm not going to talk about the pediatric recommendations, but I will tell you, if there were positive recommendations or recommendations to give albumin, I would have focused on those. All of those recommendations were to not use albumin in any specific clinical indications in pediatric patients. And similarly, in cardiac or vascular surgery, I'm not going to focus on that. And so we'll start with albumin in critical illness. And so the first recommendation is that in critically ill adult patients, intravenous albumin is not suggested for first-line volume replacement or to increase serum albumin levels. The second recommendation is that in critically ill adult patients with thermal injuries or acute respiratory distress syndrome, albumin is not suggested for volume replacement or to increase serum albumin level. I'm not going to focus on the specific subgroup, data with respect to thermal injuries and ARDS, but we'll look a little bit at the data that's informing that first recommendation. And that was a conditional recommendation with a moderate certainty of evidence of effect. So this is a very large trial published in 2004 called the SAFE trial, published in the New England Journal, which looked at almost 7,000 ICU patients who, quote, required fluid for maintaining intravascular volume. And these patients were randomized either to receive normal saline or 4% albumin, with the primary outcome being survival. And you can see here that there was no difference between groups, between the 4% albumin group and the saline group with respect to survival. And in these predefined subgroups, there were no difference between groups. It was actually in response to that study that the FDA issued another letter in 2005 that, based on the data from the SAFE study, they had resolved the prior safety concerns raised by the Cochrane Injuries Group. And so that's not to say go ahead and give albumin to everyone, but that it did not seem to be that albumin conferred increased risk, just that there was no difference between giving crystalloid or albumin. Interestingly, the surviving sepsis guidelines, which were revised in 2021, do include a recommendation to give crystalloid as a first line for resuscitation. That's not surprising. And in the 2021 update to the 2016 guidelines suggested balanced crystalloid, which we've talked about before. So also not surprising. But similar to the 2016 guidelines, they continue to suggest using albumin in patients who have received large volumes of crystalloid. And I mention that just to say, I think there are still sort of open questions about the role for albumin in this population. Certainly, no one recommends it as used for first line, but there may still be a role for albumin. I think we just need additional studies to help delineate how and when to do that. And I personally don't recommend using albumin in this setting because I don't really know when or how to interpret a statement like this. Large volumes of crystalloid is a little bit nebulous. The second study I'll highlight is the Albios study, which was published about 10 years later. And this was looking at 1,800 patients with severe sepsis who were randomized to receive either crystalloid alone or crystalloid plus 20% albumin, with the goal of targeting a serum albumin level of greater than 3 grams per deciliter. And this is going to come up again a little bit later, but the notion of targeting an albumin level, giving albumin to get albumin above a certain threshold is not something that's recommended. And indeed, in this trial, they were able to get good separation between the albumin group and the crystalloid group. So got that albumin level up to 30 grams per liter or 3 grams per deciliter. But there was no difference between the groups with respect to survival. And so targeting a serum albumin level in this population, and I'll just go ahead and say in any population, and we'll look later at cirrhotics, is not recommended. Okay. What about albumin to augment diuresis? This is something that I think that comes up in critically ill patients, but in other populations, the committee's recommendation is that in critically ill adult patients, intravenous albumin in conjunction with diuretics is not suggested for removal of extravascular fluid. I'll note that the certainty of evidence of effect here is very low. And there aren't good trials to look at here. We do have one meta-analysis of 8 studies, all of which were crossover in design, comparing co-administration of loop diuretics and albumin versus loop diuretics alone. And actually, at 8 hours in this particular meta-analysis, there was a difference in urine output or urine volume that favored co-administration of furosemide with albumin, but that effect diminished by 24 hours. And I don't think that a lot of us, I mean, maybe my cardiorenal colleagues would beg to differ, but care too much about our 8-hour urinary volume. We care about achieving effect over the course of an entire 24 hours. And albumin was not demonstrated to be beneficial for purposes of 24-hour urine volume increasing. So I would say that this is another area where perhaps additional data are needed, but based on the available evidence right now, the practice of co-administering albumin with loop diuretics is not recommended. We're nephrologists, right? So we should focus at least a little bit on the use of albumin for intradialytic hypotension. And it was the committee's recommendation that intravenous albumin is not suggested for prevention or treatment of intradialytic hypertension or for improving ultrafiltration. And one of the things I learned through this process is that the use of albumin in outpatient dialysis centers varies wildly in different parts of the world. And there are, we don't give albumin in outpatient dialysis centers, or at least here at Northwest Kidney Center, but there are places where they're using albumin in the outpatient setting, and that can be very expensive. As we've already discussed, the cost of albumin is quite costly. What do we have to inform this? Well, we don't have great data. We do have a randomized trial of albumin to prevent intradialytic hypotension in hospitalized hypoalbuminemic patients, but this was a randomized crossover design. So on one treatment, the patient would be given albumin to prevent intradialytic hypotension, and then in the next treatment, the same patient would be given saline, and it would alternate. But because of that design, we're unable to really evaluate the most clinically meaningful outcomes, survival, hospital length of stay, because challenges inherent in that crossover design. It's a little bit of a confusing figure, but the albumin group is in the dark gold here, and we'll just look at this for example. So the percent of patients who had episodes of hypotension with requiring ultrafiltration discontinuation were fewer in the group, the folks receiving albumin. So, and the folks receiving saline, 43% had at least one episode of hypotension requiring the discontinuation of ultrafiltration. 5% had 2 episodes. 5% had 3 episodes. None of the patients who received albumin had 2 or 3 episodes of hypotension, and only 31% had 1 episode. So there's some, sort of signal there suggesting that maybe albumin was more effective at preventing hypotension, but we don't really have robust data that's translating into clinically meaningful outcomes for our hospitalized patients requiring dialysis. And we have no data to inform this practice in the outpatient setting. So I would say that in general, not using albumin for intradialytic hypotension is the best recommendation based on the available evidence. At the end, I'll talk a little bit about what I do in my patients who have cirrhosis, which is slightly different. So speaking of that, so what about albumin in patients with cirrhosis? And this is where really I think the meat of the recommendations are. And there's something special or different about albumin in cirrhotic patients, which we can kind of dig into. But we'll look at recommendations for patients who are undergoing paracentesis, patients who have SBP, patients with non-SBP infections, patients with hypoalbuminemia, and then outpatients who have ascites that has been resistant to diuretic therapy. And deviating a little bit from the work of the guideline group, I will also talk about patients who have AKI or HRS, patients who have hyponatremia, and patients who have kalemic or bile cast nephropathy. Okay, so what is it about albumin and cirrhosis? And I like talking about the physiology of hepatorenal syndrome. We're not going to get too down in the weeds here, but I think we just need to kind of review this briefly so that we can think about why albumin might be beneficial in patients who do have cirrhosis. And so it starts with portal hypertension, and due to multiple circulating vasodilators, specifically I'll highlight nitric oxide here, We see splanchnic arterial vasodilation, and then a decrease in your SVR, with the end result being a low effective arterial blood volume. We really know that's the sort of hallmark of this physiology. And then in response to that, we see increased activation of arterial baroreceptors and renal hypoperfusion, which triggers all these compensatory responses, right? So we see non-osmotic secretion of ADH, which leads to water retention and hyponatremia. We see increased sympathetic nervous system stimulation, which leads to intrarenal vasoconstriction. And we see increase in RAS activation, which leads to sodium retention and vasoconstriction. This whole cascade of what we call hepatorenal physiology really starts up here. And again, I highlighted nitric oxide, which, as it happens, is bound by albumin. And so there may be, a physiological argument for why albumin would be different in this population of patients than all critically ill patients or all hospitalized patients. So the first recommendation is for albumin to prevent paracentesis-induced circulatory dysfunction, sometimes also called post-paracentesis circulatory dysfunction, circulatory collapse after a large volume paracentesis. And in patients with cirrhosis and ascites who are undergoing large volume paracentesis, defined here and elsewhere as greater than 5 liters, albumin is suggested to prevent paracentesis-induced circulatory dysfunction. Despite the ubiquity of this practice, I'll note that the evidence is not super compelling. Many of the studies are very, very old. Many of them are comparing albumin to other things that we're no longer using in practice, like synthetic colloids, like hetastarch or things like that. But nonetheless, we do have some data to suggest that this is helpful. So this is a meta-analysis looking at multiple RCTs totaling about 600 patients who are undergoing large volume paracentesis, and looking at 7 different interventions for prevention of paracentesis and to circulatory dysfunction. And if we look just at the group, the section here comparing albumin given at a dose of 8 grams per liter versus other volume expanders, it definitely favors the use of albumin. There's some other, data looking at albumin versus midodrine or other vasoconstrictors, slightly less compelling, I think. And so this guideline, in keeping with other guidelines, I'll say, like guidelines from the American Association for the Study of Liver Disease and the European Liver Guidelines, recommends albumin for patients undergoing large volume paracentesis. What about an SBP? So this is probably my personal favorite. It's weird to have a favorite indication for giving albumin, but I think that this one's perhaps the most interesting. So in patients with cirrhosis and SBP, intravenous albumin is suggested to reduce mortality. We'll say that in patients with cirrhosis and other infections, intravenous albumin is not suggested. And I'm not going to focus on the data in support of that recommendation, but no studies have successfully recapitulated in other infections what we've seen in SBP. So what is the data supporting the SBP recommendation? I think many of us are familiar with this landmark trial from the New England Journal back in 1999, looking at 126 patients who had SBP who were randomized either to receive antibiotics plus albumin or antibiotics alone. And you'll see here that in the antibiotics alone group, the 33% of patients developed renal impairment as opposed to 10% in the group that received antibiotics plus albumin.
You don't have a sweatshirt, baby?
And there was also a mortality difference. So in-hospital mortality was 29% versus 10%. If you dig a little bit into the paper, there's some interesting findings with respect to the effects of albumin on RAS activation. So in patients who received antibiotics plus albumin are the white bars, the antibiotics alone are the black bars, and you can see statistically significantly lower plasma renin activity in the albumin group at days 3, 6, and 9. This effect was persistent despite the fact that the albumin was given only on days 1 and 3. And And then if you stratify the patients according not to whether they were randomized to albumin or not, but to whether they had renal impairment or no renal impairment, you can see that the patients who had renal impairment were those that had much higher plasma renin activity. And so, kind of putting this picture together, it may be that albumin's effect on that cascade of hepatorenal physiology, and specifically in binding nitric oxide or other vasodilators, and leading to decreased RAS activation may be part of the story for why these patients did develop less AKI and had a mortality benefit. So what about targeting a serum albumin level? I sort of alluded to the fact that we were going to talk about this again. So in hospitalized patients with cirrhosis who have hypoalbuminemia, defined as an albumin level of less than 3, giving repeated intravenous albumin to increase albumin levels to above 3 is not suggested to reduce infection or kidney dysfunction or death. And this really comes out of the ATTIRE trial, which was published in 2021, incidentally in the same issue of the New England Journal that the confirmed terlipressin trial was published in. Looking at 777 patients with cirrhosis and hypoalbuminemia who were randomized to get either 20% albumin to get their albumin up or just standard care. And what you'll see here is that there was no difference in their composite primary endpoint, which included incidence of new infection, kidney dysfunction, or death. But importantly, there were more serious adverse events, including pulmonary edema, in the albumin group. And I guess that's not terribly surprising. You're giving albumin based on a serum number that may not need very much without really critically thinking about the patient's volume status in that circumstance. And so, so I think it's fair to say that there's no momentum or support for giving albumin to target a serum albumin level. And I'll just quickly say that I think the converse in some ways is also true. I don't withhold albumin from patients who have higher or even normal albumin levels if they have an indication like SBP. Okay, so the last recommendation from the group that I'm going to touch on is outpatient albumin infusions. So in outpatients with cirrhosis and uncomplicated ascites, despite diuretic therapy, IV albumin is not routinely, and that routinely is kind of doing a lot of work, suggested to reduce complications associated with cirrhosis. And, I think the punchline here is that we probably just don't have enough evidence yet for whether or not this is beneficial. We have 2 large studies, the first of which is open label, and that's important. 440 outpatients who had decompensated cirrhosis who were randomized to receive weekly infusions of 40 grams of albumin or standard of care. And you can see here actually that with respect to many of these complications like SBP, other infections, hepatic encephalopathy, standard medical therapy plus albumin was better. And liver-related and all-cause hospitalizations were lower in the group that received albumin. But again, this was open label, and when a subsequent study of 196 outpatients with cirrhosis was published, the effect kind of went away, and this one was placebo-controlled. So this was 200 patients who were randomized to receive a combination of daily midodrine and then every other weekly infusions of 40 grams of albumin versus placebo. And while there was a decrease in RAS activation in the group that received albumin, you can see statistically significant decrease in plasma renin activity and aldosterone. There was no difference in the probability of developing complications. And so I think that the jury's still out on this. Obviously, it would be a huge undertaking to start administering albumin in the 4 South infusion clinic here or in any other hospital to every outpatient with cirrhosis and resistant ascites. So I don't think we have sufficient data at this point to recommend that. And then what about albumin for HRS? So the committee was unable to make a recommendation on this. There are prior systematic reviews on the treatment of hepatorenal syndrome, but there have never been any randomized trials examining albumin versus placebo for these patients. Pretty much every HRS study that's ever been done looks at the combination of vasoconstrictors and albumin, and the variable that's manipulated is the type of vasoconstrictor. Albumin is really fixed. And so the committee was unable to make a recommendation about this. I will say we all know we use albumin in these patients. So this is from the most current iteration of the AASLD guidelines for diagnosis of AKI in patients who have cirrhosis. And you'll see here the obligatory albumin challenge, right? So if you have AKI and cirrhosis, we typically give albumin 1 gram per kilogram for 2 days. There's a movement towards shortening that time, but for 2 days, and then use that in our diagnostic algorithm for determining whether or not patients have HRS. So we do use albumin in these patients. And to the extent that we have any sort of guidelines for doing so, I will note that both the AASLD and the European guidelines recommend albumin in combination with vasoconstrictors for patients who have HRS. I'm only aware of one study that has ever even obliquely looked at this, and this is a prospective non-randomized study of patients who received either terlipressin plus albumin or terlipressin alone, but this is non-randomized, and so you have to imagine that there probably is a difference between groups for why patients got albumin with their terlipressin or not. You can see each line here represents a different patient. So it does appear that the terlipressin plus albumin group has an overall downward slope in the trend of their serum creatinine compared to the terlipressin group, and that the probability of survival is better in the terlipressin plus albumin group, but no one has since then ever included an albumin versus placebo in their studies of HRS. So 2 more quick notes, and then I'll be done. So there are a couple of areas where I use albumin for which the evidence is pretty scant, but that both Dr. Pitchler and I think would say we've seen success. And one of them is using albumin for the treatment of hyponatremia in cirrhotic patients. These are like those great old studies where you could just publish your trends from each individual patient and what happened. And so this is looking at individual patients who had hyponatremia and what happened to their serum sodium when they've been given albumin. And I'll tell you the punchline is when they got albumin, like this patient, the sodium just shot right up. And what we see is that, I think in part because of restoring intravascular volume, but also in part perhaps by decreasing systemic vasodilation, you will use albumin in our patients with cirrhosis to treat ADH-mediated hyponatremia. And I don't want to, step on Dr. Pitchler's corner here, kalemic nephropathy. He could do this more justice than I could, but we think about kalemic nephropathy or bile acid-mediated injury in our patients who have really high bilirubins, which is mediated by a number of things, tubular dysfunction, bile cast formation, altered glomerular hemodynamics. And we know that albumin binds both to bile acids and to bilirubin. And so we have seen success in our patients with suspected kalemic nephropathy administering daily infusions of albumin. I'm out in the area of expert opinion and not hard evidence here, but I just thought it was worth noting that we do see albumin being beneficial in those folks. And so I'll end here with a summary of how I tend to use albumin. I routinely use it for patients undergoing large volume paracentesis, for patients with SBP, for diagnosis of HRS in cirrhotic patients with AKI, and in conjunction with vasoconstrictors. And I'll underscore that the first 2 of these are supported by the guideline. I sometimes use albumin to augment diuresis or for intradialytic hypotension in my patients with cirrhosis, which I didn't talk about at length, but I do think that those patients behave a little bit differently. And as I discussed, I do sometimes use it for treatment of hyponatremia or bulimic nephropathy. And then importantly, I don't use albumin for volume resuscitation in patients who don't have cirrhosis. I don't use it to augment diuresis in patients without cirrhosis. I don't use it for intradialytic hypotension in patients without cirrhosis. And I don't target a specific serum albumin level in any patient. And that's all I have. Thank you.
Thanks so much, Cary. Long-awaited follow-up from your renal grand rounds talk many years ago. There's a few questions in the chat that kind of well, several of your keen colleagues have started to address, but kind of center on this question of, you mentioned not a lot of evidence for routine albumin in these kind of generalized situations, but maybe we want to think ourselves as being more nuanced. David asks about, is there indication in really hypoalbuminemic patients? Justin asks about subpopulations that might benefit from augmented diuresis. So if you have any general thoughts about that or those particular situations.
I think I'm going to have to sit down and go through the chat and respond perhaps to each of those. Why don't I address those via chat? I see a couple of hands up. I don't know. Steve, yours went up first.
Thank you. And the chat did mention hypoalbuminemic patients from the point of view of diuretics. The SAFE trial, the baseline albumin was 2.7 grams per deciliter. And then the other argument you quoted from the New England Journal in 2014, the baseline albumin was 2.4. And in patients that have had very low albumin, like 1, I've been inclined to still consider albumin for volume resuscitation. And that's a category that you said you would not use albumin. So I'm wondering if there was any discussion in this group you were involved in regarding patients who had extremely low albumin and hypotension, because in some ways they're not represented in those trials if the albumin is, for example, 1.0.
Well, I don't think we have good evidence per se for giving patients with severe hypoalbuminemia albumin, but I don't think we have evidence of it being harmful. And I think you could make a good argument for why it might be helpful. And so I think this is maybe an illustration of where guidelines are a good start to the conversation, but don't necessarily need to rigidly dictate practice if you have a good reason for deviating from it. And I think, to your point, an albumin of 1 is different than an albumin of 2.4 or 2.8 probably. And, that may be the patient who you would give albumin in addition to crystalloid. I still think we're not going to reach for albumin as the first line in a septic patient, even if their albumin is that lower. I probably am not. I'm going to use balanced crystalloid. But I think in the same way that I use albumin in cirrhotic patients for, in areas where we don't necessarily have RCTs, but we have, a biologically plausible argument for what we're doing, I think that's fine. Guidelines are just guidelines and not rigid structures.
Okay, well, thanks for a great talk. Appreciate it.
Ian? Ian, we can't hear you, but it looks like you're unmuted. So still can't hear you. Sorry, not sure how to troubleshoot that. Maybe you could drop a question in the chat if it's amenable. And actually for time, we might let Cary, I see you maybe frantically responding to comments in the chat, Cary, and thanks for putting up that slide so Leah can take a screenshot. So thanks for a great talk. We'll move on